Hi, everyone. I'm Laura Gottlieb. I'm a professor of family and community medicine and director of the Social Interventions Research and Evaluation Network, or SIREN, at UCSF. The planning committee asked me to focus this talk today primarily on the state of the science around social risk screening, because screening for social adversity is one fundamental component of the social care framework we developed for the National Academy of Medicine report on integrating social care into the delivery of healthcare in 2019. The consensus study report is freely available online and might be helpful background for participants in this workshop thinking about the range of interventions that can be impactful for patients living with cancer. I like the framework because it provides a useful organizing tool to think about the different types of healthcare activities around social care, including not just efforts by healthcare systems to identify the social risks and assets of defined patients and populations, which we will talk about today, and we refer to in the report as awareness strategies, but also types of interventions that might follow to address or otherwise mitigate the impacts of social adversity on health outcomes. So just briefly, those interventions include activities intended to improve outcomes for individuals being seen in healthcare delivery settings, as well as activities that aim to improve social conditions at the community level. But as requested, I'm going to really shift to focus on the center of the framework and share a little on what we know about awareness. Or again, these are strategies undertaken by healthcare systems to gather information about patients' social conditions. So awareness actually encompasses many different activities, including efforts where maybe healthcare staff just ask patients about their social contexts, whether in clinical settings or maybe via intake forms like insurance health risk assessments. There are also healthcare systems that are buying big consumer data about patients' purchasing history, home ownership, or bankruptcy experiences. It also might include activities where health systems use patient address data to link patients they're seeing in clinic with neighborhood level information about social conditions, like the Neighborhood Opportunity Index or the Deprivation Index. Despite that kind of wide range of potential awareness activities, much of the news, much about what we hear about awareness has really revolved around these new social risk screening tools that have been endorsed by groups like the National Academy of Medicine, the American Academy of Pediatrics, American Academy of Pediatrics, American Academy of Family Physicians, the American College of Physicians, and the National Association of Community Health Centers. There has been, I would say, a kind of vexing lack of consistency in these different tools, which don't always include the same social domains. And even when they cover the same domains, they sometimes will include different measures for those domains. They also can differ considerably in length. So I just threw up here some sort of a summary of 3 of the most common tools that we've seen in healthcare settings. But the sideways reference from our SIREN website will take you to a list of many other tools that have emerged in this space and show you some of the differences between them. Our team was especially curious not only about what tools exist, but how patients feel about being asked about their social conditions in the context of healthcare. So we conducted a 1,000-person survey in 10 different primary care and emergency medicine clinical sites around the country, including 4 pediatric settings, in which we asked patients about whether they considered it appropriate to be asked about social risks in healthcare settings, and moreover, how comfortable they were having any disclosed data about social risk being incorporated into the electronic medical record. The results are summarized in these pie charts, showing that the majority of people are either very or somewhat comfortable with both being asked about social risks and having that information documented in the EHR. The survey showed no differences in patient acceptability across 2 different screening tools that we used in the study, and acceptability was not significantly associated with race, age, or gender. So given that we have some social risk screening tools, and these tools are generally pretty acceptable to patients, you might wonder about the extent to which social risk screening is actually happening in healthcare settings around the country. So this is a slide from my friend and colleague at UCSF, Dr. Tressa Fraze, who analyzed findings from a national survey of healthcare organizations, including hospitals and outpatient practices. Respondents indicated that the majority were already routinely screening for at least one social risk factor, and somewhere around 20% reported screening for all 5 social risk factors included in a tool developed by the Center for Medicare and Medicaid Services that included housing, food, utilities, transportation, and IPV. Now, that may not be the whole story. So the extent to which screening is really happening is a little more uncertain. This is from work our team did showing pretty dramatic differences in the results of 23 different national surveys, each of which was trying to gauge the frequency of social risk screening in healthcare settings. So Dr. Fraze found these very high numbers. But when we found a survey asking patients if they had ever been screened, the numbers were considerably lower. And that was true across all the different surveys that we saw in this field. The numbers range really dramatically. This is probably the most pronounced difference. Still, we're starting to understand some of the facilitators for social risk screening. So payment incentives can be used to increase screening adoption. This is a slide from a private payer that incorporated social risk screening as a reimbursable quality measure. We're certainly seeing that happen more and more among both private payers and state Medicaid agencies. Technology is another facilitator for screening and for related social care interventions too. So as many of you know, major EHR vendors and many individual health systems now incorporate social determinants information into the EHR so that data about patient social conditions can be more easily accessible to providers at the point of care. So the upshot here is that we have some screening tools. We think patients are okay with screening. We know about some of the facilitators for implementation. But there still are a lot of unanswered questions that are facing this field, including questions about the possible unintended consequences of asking about patients' social risk or doing social risk assessments and marrying the data about social risk to healthcare data. So for instance, could social risk screening in healthcare systems exacerbate patients' experiences of mistrust or perceived or actual discrimination? Does screening contribute to moral distress in providers if screening isn't paired with adequate resources for addressing any uncovered needs? Other questions I think have been planted by Stacy Lindau's lab in Chicago, who has asked some important questions about screening whether screening is even necessary. Maybe we could all just provide information about community and government resources to all patients and skip screening. Part of their rationale for that is that they found in their research that patients are quite likely to share any resource information with their networks. Which would mean that, whether or not a particular patient has a need, they are passing that information along to people that do have needs. So these and similar questions might be topics to consider as the discussion unfolds during the workshop and hopefully subsequently. I'll take just one more remaining minute to note that some health systems and researchers are exploring alternatives to patient-focused screening, since that kind of screening can be very clinic resource intensive, which would be a big obstacle to implementation in busy clinical settings. But the pros and cons of patient versus neighborhood level data collection have not been clearly articulated. So this slide is based on data from a study we did in collaboration with Ochen's network of over 600 community health centers, where we had data that had been collected both from patients about social conditions and address data based on the census tract. So neighborhood level data compared to patient reported data. And what we found was that in 40% of cases where we had both sets of data, patients who were self-reporting some form of a financial resource drain would not have been picked up if we had relied solely on neighborhood level data. So the upshot there is just that there's a lot more to learn about when to use which kind of data. Thank you so much.